Well, hello and welcome. My name is Shalini Paruthi, and I would like to thank you for joining us for this cardiovascular and sleep webinar. Now, this is part of the National Healthy Sleep Awareness Project, and today we are delighted to have Dr. Virend Somers with us. He completed medical school at the University of Natal. He did his PhD at the University of Oxford and completed residency and fellowship at the University of Iowa. So we are delighted to have you here, and we're very interested in what you will tell us.
Thanks very much, Shalini. And I'll be talking about sleep apnea and cardiovascular disease, specifically obstructive sleep apnea. Talking about the associations with cardiovascular disease, what's the evidence for causality, and the therapeutic implications. My disclosures are shown in this slide. Now, the reason we're interested in obstructive sleep apnea is because of its high prevalence, and some of the best data we have on prevalence come from Terry Young's work with the sleep cohort study at the University of Wisconsin-Madison, where they showed that if you looked at a community sample, about 1 in 4 middle-aged men and 1 in 10 middle-aged women had significant sleep apnea. Now, the reason I, as a cardiologist, my colleagues are interested in obstructive sleep apnea is because of its interactions with a breadth of cardiovascular diseases, including high blood pressure, atrial fibrillation, stroke, heart failure, cardiac ischemia, and sudden death. Now, how strong is this interaction? Well, if you look at patients with hypertension, depending on your sample, of course, about half of them will have significant sleep apnea. Similarly, patients with heart failure, 1 in 4 will have obstructive apnea, and maybe 1 in 4 will have central apnea. About a third of patients with acute coronary syndromes will have obstructive apnea. And when you look at people with a full-blown myocardial infarction, that number increases to between 50 and 60%. And of course, when we look at people with stroke, 60% will have obstructive apnea, but we, again, don't know if the obstructive apnea preceded the stroke or to some extent is there because of the damage to neural control mechanisms centrally. Now, I'm going to cover 5 different areas today. We'll talk about the mechanisms of disease. What is it about obstructive sleep apnea that could go on to predispose to the development and progression of cardiovascular disease? Then talk about 3 fairly common cardiovascular conditions: high blood pressure, atrial fibrillation, heart attacks, and sudden death. And then last, we look at data from a recent randomized controlled trial, one of the few that have been done in obstructive sleep apnea, look at the results and try and understand where we go from here. So in terms of mechanisms of disease, probably the most compelling mechanism is sympathetic activation, mainly because of its strong relationship to cardiovascular disease and the fact that obstructive apnea is a potent activator of increases in central sympathetic outflow. Now, when you measure sympathetic activation, you can do it by measurement of plasma catecholamines or urine catecholamines. In the studies I'll show you, we use microneurography. Here you see a microneurographic electrode compared to a 22-gauge needle. We insert that electrode into a peripheral nerve, either in the leg or the arm. In this case, the peroneal nerve in the leg. We find the nerve by stimulating from the outside and then insert an electrode into the nerve. Here's a reference electrode in red. And essentially what we're doing is tapping into the vasoconstrictor signal going from the brain down to the peripheral blood vessels. And we do this because apnea is a very dynamic phenomenon. The level of sympathetic activation changes significantly during and at the end of the apnea, and catecholamines don't really catch this. The only way to see this dynamic change is by tapping into this sympathetic vasoconstrictor signal going to the blood vessels. And when we do this, what we see is that patients with newly diagnosed obstructive apnea who are free of any cardiovascular disease have significantly higher levels of sympathetic drive than similarly obese people proven to be free of obstructive apnea. Now, both these groups are normoxic, breathing normally, they're wide awake. Neither group has any other disease except for this group on the right having significant newly diagnosed obstructive sleep apnea, which has never been treated. Now, the sympathetic activity is indicated by these spikes, and you can think of each spike as really reflecting the release of norepinephrine at the neurovascular junction. And the taller the spike and the more frequent the spikes, the greater the norepi release. And so what we can deduce from this is that people with obstructive apnea have fairly high levels of tonic sympathetic drive, even when they're awake, breathing normally, and not hypoxemic and free of any other cardiovascular disease. So when they go to sleep, it becomes more striking. This is an awake, newly diagnosed obstructive apneic patient, otherwise healthy, high sympathetic activity, breathing normally, intra-arterial blood pressure 130/60. He goes to sleep. He's in REM sleep, which is the time that apneas are worst. And what we see is that with each apnea, because of hypoxemia and hypercapnia activating the chemoreflexes, what we get is a progressive increase in sympathetic activity. And the sympathetic activity is highest towards the end of the apnea, because that, of course, is when hypoxemia and CO2 retention is worst. So you get this vasoconstriction, and intra-arterial blood pressure gets up to 240/130 in an individual who is completely normotensive when he was awake. So you treat them with CPAP, and you find sympathetic activity decreases, breathing is better, and blood pressure is lower. So there are other mechanisms that are involved in the responses to obstructive apnea, and these come again from the fact that obstructive apneic patients are hypoxemic, then they reoxygenate when they breathe again. And this hypoxemia reoxygenation phenomenon is a fairly potent trigger for a number of pathophysiologic mechanisms, including the development of inflammation. Then, of course, you've got hypercapnia, you've got these intrathoracic pressure changes. People with obstructive apnea generate a significantly negative intrathoracic pressure that can have deleterious effects on afterload and on left atrial mechanics and size. Then you've got arousals from sleep that, again, may be a trigger for these intermediary mechanisms, which are shown in the middle panel: sympathetic activation, endothelial dysfunction, oxidative stress, inflammation, increased coagulability, and metabolic dysregulation. Because of time, I'm not going to be able to cover all of these intermediary mechanisms, but we will cover the bulk of these diseases, the endpoints of these intermediary mechanisms: high blood pressure, heart failure, arrhythmia, including atrial fibrillation, cardiac ischemia, including coronary artery disease, nocturnal angina, and maybe sudden death, and then stroke, which we won't cover for the purposes of today. So the key question we have to ask ourselves is, does obstructive apnea cause cardiovascular disease? And if it does treating the sleep apnea actually modify cardiovascular outcomes, which is the real reason that we want to diagnose sleep apnea, beyond, of course, the concept of alleviating sleepiness. So we'll start with the first question: does CPAP treatment of obstructive apnea reduce blood pressure in patients with high blood pressure? So let's talk then about hypertension and think about the prevalence of hypertension, rather the incidence, the development of new hypertension in untreated patients with obstructive apnea. And these data again come from the Wisconsin Sleep Cohort study, where Paul Peppard and colleagues working with the cohort previously shown from Terry Young's data reported that as your apnea got worse based on your AHI, your likelihood of incident or new onset hypertension increased, so much so that when your AHI was more than 15, there was a threefold increased risk of new hypertension, regardless of these other risk factors for high blood pressure: age, sex, smoking, alcohol, BMI, and neck circumference. Now, what happens when you treat patients with obstructive sleep apnea and hypertension with CPAP? These are data from the Lancet, from Pepperell et al., showing baseline measurements in two groups: people who received subtherapeutic or controlled CPAP in the open circles and therapeutic CPAP in the closed circles. And you can see that prior to initiation of the study, both groups had fairly similar blood pressure levels, and during the nighttime, which is shown here, if anything, subtherapeutic group had a similar blood pressure to the controls or to the therapeutic group, because overall during the night these numbers equilibrate. Now, at 1 month after treatment, there was a clear digression in the blood pressure values. Here's the subtherapeutic CPAP group in the open circles and the therapeutic in the closed circles. And both during the daytime and during the nighttime, if you look here, the black circles are above the open circles, and here the black circles are clearly below, showing a consistent reduction in nighttime and daytime blood pressure with CPAP therapy. Overall, the mean blood pressure fell by about 3.3 millimeters of mercury. Now, there's a number of studies looking at the effects of CPAP treatment on blood pressure levels, and several meta-analyses have been very consistent in showing that overall, when you put all these studies together, the fall in blood pressure with CPAP treatment of OSA in patients with hypertension is present, but it's very, very modest, between 2 and 3 millimeters of mercury generally. And what you see is that there is a fairly significant spread between studies which show very little change and studies which show a striking change in blood pressure levels as high as 10 or more millimeters of mercury fall in blood pressure with CPAP treatment. Now, how do we explain this heterogeneity in the results of treating patients with obstructive sleep apnea and hypertension with CPAP? So there's several things that define how effective we are going to be in lowering blood pressure if we treat with CPAP. The first is, and it's not covered in the slide, but is very important and has been consistent across studies, is how much do patients use CPAP therapy. As a general rule, the more the patients use CPAP during the night, the more effectively their blood pressure is lowered. The other factor that comes in is nocturnal hypoxemia. Here we see data showing the change in 24-hour mean blood pressure in people who are hypoxemic in the open circles and without hypoxemia in the closed squares. And the ones who have significant nocturnal hypoxemia when treated with CPAP tend to have the most striking fall in blood pressure. The other factor that seems to define the blood pressure response is sleepiness. And this sleepiness will come up in other cardiovascular issues that we'll discuss later in the talk. But people who are sleepy, shown in the open circles, have a greater fall in blood pressure with CPAP treatment than those who aren't sleepy. So duration of CPAP use, degree of nocturnal hypoxemia, degree of sleepiness, and I think also the severity of hypertension all come in to predict which patients are going to be more responsive to CPAP using the endpoint of blood pressure lowering. Now, let's talk about atrial fibrillation. When you look at patients with sleep apnea, they tend to have higher levels of C-reactive protein compared to similarly obese people proven to be free of sleep apnea on full overnight polysomnography. Both groups have similar BMIs. It's just that the sleep apnics have this high level of C-reactive protein. Now, CRP has been implicated in cardiovascular disease, but it also seems to link to the development of atrial arrhythmias. These data from Mina Chung from the Cleveland Clinic show that if your CRP level was high today, your likelihood of new onset atrial arrhythmias, including atrial fibrillation, was significantly greater 4 years down the road. Now, the other thing about sleep apnea and the atrium is that probably because of the significant negative intrathoracic pressures that develop during obstructive apneic events, we may be getting an increase in atrial size. So if you think about the fact that your atrium is a thin wall structure in the chest, and you repeatedly, hundreds of times a night, subjecting this thin-walled atrium to negative intrathoracic pressures that would tend to stretch the atrium repetitively and intermittently, then you would think that perhaps his atria would get a bit bigger. And in fact, when we looked at people with newly diagnosed sleep apnea who had no other diseases, no hypertension, no diastolic dysfunction, etc., what they had compared to similarly matched BMI, gender matched people without apnea was these apneics had higher left atrial volumes, not hugely big atria, but certainly at or slightly above the upper limit of normal. So if you think about sleep apnea, you've got hypoxemia, sympathetic vagal activation, these blood pressure surges, transmural pressure gradients, and systemic inflammation, which I didn't talk about. All of these are the same things that cause atrial fibrillation. And what is the evidence that people with obstructive apnea tend to develop AFib? These are data from Apur Gami when he was in our lab, and what he did was he looked at people who underwent polysomnography, none of whom had atrial fibrillation. And he followed them up, and he found that those with obstructive apnea compared to those without had a greater risk of new onset or incident atrial fibrillation. And this seemed to be linked to the severity of the apnea. Those with mild, moderate, severe apnea had incremental levels or increasing levels of risk of incident atrial fibrillation. By the way, the most predictive marker of whether or apnea-associated marker of whether someone would get atrial fibrillation was their level of nocturnal hypoxemia, more strongly so than their apnea-hypopnea index. So what about people who already have AFib? If you have atrial fibrillation, you're coming to cardioversion, you will have a 50% likelihood of having severe sleep apnea as compared to a 1/3 likelihood in a general cardiology population. And when we cardiovert these patients, these are the data in terms of likelihood of recurrence of AFib over a year. The white bar shows people whom we cardioverted. We didn't know they had sleep apnea. If they had sleep apnea, we didn't check. 50% came back in a year with recurrence of AFib. The yellow bar shows people who had sleep apnea, and the apnea was treated. And they had a 40% likelihood of coming back in a year with AFib recurrence. These are people who are cardioverted, and they had sleep apnea, but the apnea was not treated. They had an 80% likelihood of coming back with AFib recurrence. Now, these data have been complemented by other data, including using ablation for treating atrial fibrillation. We generally used to treat AFib with electrical cardioversion, which shocked the heart back to sinus rhythm. More and more, we're using ablation, pulmonary vein isolation, or PVI. And the data with PVI are also very similar. Here's data from Fine and colleagues showing atrial fibrillation-free survival in two groups of people, both of which underwent PVI. Here's a PVI plus, and both groups had OSA, OSA plus, OSA plus. The red line shows people who were treated with CPAP, CPAP plus, and these are people who weren't treated with CPAP for their apnea. And if you had sleep apnea and you underwent PVI and you were treated with CPAP for your apnea, your likelihood of AFib-free survival was significantly greater than if your apnea was not treated. Now, these are observational data, which also show that the hazard ratios for recurrence of AFib after PVI is linked to left atrial size, which we know tends to be greater in people with obstructive apnea, but also linked to whether or not they're treated with CPAP. Hazard ratio of 0.7 if your OSA is treated with CPAP, hazard ratio threefold greater, 2.1 if your OSA was not treated with CPAP. And here's data from a meta-analysis looking at patients who were treated either with cardioversion or PVI, looking at their likelihood of recurrence of AFib. And you see that no PVI, in other words, cardioversion in these studies at the top, and post-PVI, pulmonary vein isolation, shown in the bottom list of studies. The data are fairly consistent across the board. They show that if you use CPAP to treat apnea, you tend to have a lower recurrence of atrial fibrillation. Now, again, these are totally observational data. There are no randomized controlled trials that have been reported showing whether treatment of sleep apnea actually prevents AFib recurrence. These are data we are currently awaiting, bearing in mind that we need to really be sure that we have extended durations of treatment of obstructive apnea to prevent AFib, because AFib can be triggered instantaneously. It's not so much a cumulative effect of stress as the effect of an event. Say, excessive vagal and sympathetic drive occurring simultaneously, which often happens with apnea, can trigger AFib. So we need to be alert to the fact that perhaps we need extended periods of treatment, maybe complete treatment of obstructive sleep apnea, to prevent the recurrence of AFib after cardioversion or pulmonary vein isolation. Now let's talk about heart attacks and sudden death. You've seen these data earlier. This shows the sympathetic activation, blood pressure increase, almost marked at the end of apnea when you've got high levels of catecholamines in the bloodstream. You've got this slowing of heart rate due to vagally induced bradycardia. You've got very high blood pressure levels. You've got marked vasoconstriction. You've got hypoxia, hypercapnia, respiratory acidosis. All of these come together to increase the risk of a cardiac event, one would imagine. And in fact, people with obstructive apnea do tend to develop ischemia at night, presenting with angina. And here's a patient reported by Franklin and colleagues in the Lancet showing an apneic event occurring at 4:46 a.m. And that apneic event resulted in ST changes. This shows an index of ST depression, which indicates that the heart is not getting enough oxygenation. Here you see apnea associated with ST depression linked to angina, waking the patient from sleep. These data are consistent with other studies showing that as you get worsening levels of nocturnal desaturation on the horizontal axis, your likelihood of ST depression, shown on the vertical axis, increases significantly, so much so that the worst desaturation was linked to a higher likelihood of cardiac ischemia or ST depression during the night. And how does this link to actual myocardial infarction? These are data from Fatima Kunyoshi when she was working with us, and what she did was looked at people coming to St. Mary's Hospital with acute myocardial infarction, all of whom had their MI announced by the symptom of chest pain. She used chest pain because that allowed her to define what time the heart attack actually occurred. And what she found was that if you came in with a heart attack and were subsequently found not to have obstructive apnea, and by the way, all the patients in this study had no prior diagnosis of obstructive apnea. So if you were found after your heart attack not to have obstructive apnea, your heart attack tended to occur between 6 a.m. and 2 p.m. After waking from sleep. Very few, less than, more like 16% occurred during the nighttime hours, 10 p.m. to 6 a.m. But if you had a heart attack and you were found subsequently to have obstructive apnea, newly diagnosed apnea, you tended to have your heart attack during the nighttime in the yellow bars. Between 10 p.m. and 6 a.m., about 42 to 43% of patients had their heart attacks then. And it was more likely to occur at night than at any other equivalent 8-hour period of the daytime. So if your patient has a heart attack during the night, wakes him from sleep, think about obstructive apnea. because when you follow these patients up, those with the worst desaturation, shown in the blue lines here, have the highest likelihood of a major adverse cardiovascular event or MACE developing. About 50% of the tertile with the greatest desaturation had a major adverse cardiovascular event over a 4-year follow-up. And it seemed to be linked to the severity of desaturation. So the least significant desaturators were the ones with the least likelihood of a major adverse cardiovascular event. Now, what we don't know is whether treating these patients with CPAP will actually make a difference to their outcomes. We don't know that. All we know is that sleep apnea severity seems to be linked to prognosis after MI. Whether treating the sleep apnea with CPAP improves that prognosis is still not known. Now let's talk about sudden death. And here I'm going to show you data from Purgami's work, where he looked at people in the Olmsted County area who died suddenly, and in whom we knew with reasonable accuracy the time of death, and we knew whether or not they had sleep apnea, because just before they died, a few years before they died, they'd had a sleep study, and we knew that yes, they had apnea, or no, they did not have apnea. And what Apur did first was look at the literature generally. And he found that the literature would predict that 16% of sudden deaths would occur at nighttime between midnight and 6 a.m., with the bulk of them occurring in the morning after waking from sleep between 6 and noon. Now, these are data from the literature. When he looked at his study data, people without obstructive apnea tended to also die mainly in the morning if they died suddenly, 41% between 6 and noon, and 20% between midnight and 6 a.m. Now, the patients who were known to have sleep apnea actually tended to die at nighttime. Here's data shown in orange. 46% died during the nighttime hours between midnight and 6 a.m., with only 20% dying between 6 a.m. and noon. Now, these data suggest that having sleep apnea or obstructive apnea would affect the timing of your sudden death episode. Those data don't really tell you whether the overall risk of sudden death is increased. And we had to look at about 10,000 plus people, 10,700 people. What Purgami did was follow these people up for an average of 5.3 years. And what he found was that, yeah, sleep apnea actually tended to increase the overall risk of sudden death. And the lowest O2 sat is shown here, less than 78, above 78 in the red line. And the overall risk of sudden death, regardless of the time of day it occurred, was increased almost twofold, hazard ratio 1.81 in people with nocturnal desaturation secondary to their apnea. So again, it wasn't really the AHI as much as how low the oxygen fell that predicted whether or not somebody would have a sudden death episode. So to summarize the conclusions in these 10,700 patients, all of whom had polysomnography, and taking into account the expected clinical variables and other sleep parameters which would be expected to affect sudden death, it was the lowest O2 sat which independently predicted the likelihood of sudden death, and that lowest O2 sat seemed to be below 78%, increasing risk by 81%. So what I've done so far is talked about the mechanisms of disease, what happens during an obstructive apneic episode, and how all of these changes, and specifically sympathetic activity, but also inflammation, intrathoracic pressure changes, etc., could be linked to high blood pressure, atrial fibrillation, cardiac ischemia, and perhaps even myocardial infarction and sudden death. So you would think that based on all these data, that treating apnea would be a powerful way to prevent cardiovascular events. And so the SAVE study, which most of you are familiar with, where people were randomized to CPAP or no CPAP, and the people selected were people with obstructive apnea and existing cardiovascular disease. These data was surprising in that there really was no difference in outcome between the CPAP and the usual care group. In other words, there was no evidence that CPAP actually prevented cardiovascular events, the primary endpoint being composite of death from cardiovascular causes, MI, stroke, hospitalization for heart failure, unstable angina, or TIA. There was no evidence that this composite endpoint was diminished by treatment with CPAP. Now, why would this be? First, let's consider that CPAP did have some benefits, particularly in terms of reducing days off from work because of poor health. That was significantly reduced. Accidents causing injury had a tendency to be lower in the CPAP group. So CPAP was not without some benefit, but it actually did not show cardiovascular benefit, which is what we were all expecting. And so why was this? Well, to understand it, we have to first accept the fact that maybe CPAP just does not prevent cardiovascular events in people with bad apnea and established cardiovascular disease. That may just be the fact, and we may have to accept that. But we also need to look at possible other explanations. And when you look at the SAFE study, what they did was they took non-sleepy patients. They also excluded the patients with the most severe nocturnal desaturation. Average CPAP use was only 3.3 hours per night, and the data were analyzed on the basis of intention to treat. On-treatment analysis of CPAP suggested that there was a reduction in stroke in those who use CPAP more than 4 hours a night. So there is some signal there suggesting that maybe CPAP can be beneficial if you use it long enough. Now, what are we to make of the data? First, the fact that the most severe desaturation patients were not included suggests that a high-risk group was left out of the trial. And so that is one consideration. The other is the issue of only using CPAP for 3.3 hours per night. Now, as you know, obstructive apnea is worse during REM, and REM tends to occur mainly during the second half of the night, and that's when obstructive apneic events are worst. So if you're treating the first 3.5 hours of sleep and leaving the second half of sleep unprotected, that may be a problem, and that may be enough of an apnea burden to mitigate any beneficial effect of CPAP. The other issue relates to acclimation to a stress. Now, here's a slide showing a patient on CPAP therapy with then a reduction of CPAP pressures, therapeutic pressures, by about 2 or 3 centimeters of water. And so the apnea recurs. And with the apnea recurrence, you find high sympathetic drive and an increase in blood pressure. So the point here is that we need to think carefully about whether it is healthy for us to prevent apneas initially and then take the treatment away and then leave the body exposed to severe apneas without having given it the chance to acclimate to the apnea stress. We talk about ischemic preconditioning, and it may not relate completely to the issue of only partial treatment of obstructive apnea overnight, but the body does have the capacity to acclimate to a stress. For example, if you have high levels of catecholamines, then you get downregulation of your adrenergic receptors so that the catecholamines have less of an effect on your physiology. But if you, and this is just pure hypothesis, if you treat with CPAP and you prevent that acclimation to high sympathetic drive, and then you withdraw the CPAP and you have high levels of sympathetic activity, we don't know if that is in itself having any harmful effects. Certainly in the case of atrial fibrillation, one would imagine that even brief high levels of sympathetic and or vagal drive may trigger the onset of AFib. Now, whether this applies to cardiovascular events generally, we don't know. but it certainly is something to bear in mind. The other issue is leaving out people with sleepiness. Now, these are data from our study on patients after myocardial infarction, and it shows three groups of people. It shows people with severe sleep apnea, AHI more than 15, who were sleepy. We used a cutoff that was different from the SAFE study, but the concept that I want to convey is that of the effect of sleepiness as a risk predictor for cardiovascular events. Here's people with a significant level of sleep apnea and excessive daytime somnolence, and this is MACE probability. In the blue lines are people with the same level of sleep apnea severity, more than 15 per hour, without EDS or daytime somnolence. And the green lines are people who just don't have any apnea at all. AHI is less than 5. And all of these patients had had a previous heart attack, and we looked at the probability of a major adverse cardiovascular event over 4 years. And you see here that, yes, the risk was very high in people with bad apnea and daytime somnolence, but not so high if you didn't have daytime somnolence, even if your AHI was fairly high. In fact, at 3 years, 36 months, you will see that the difference in MACE, or a major adverse cardiovascular event, between people with bad apnea who were not sleepy and people with no apnea at all was really not very striking. So the message here is that if you really want to see a difference in outcome with treating apnea, perhaps we absolutely need to look at apneic patients who are sleepy, because that sleepiness seems to be a factor in predicting who is at greatest risk. So what I've tried to do then is we talked about the mechanisms of disease, we've talked about actual disease conditions, and then talked about the fact that the SAVE results are so much different from what we would have expected based on the pathophysiology and the strong associations with cardiovascular disease, certainly counterintuitive. And while we need to recognize that the SAFE study may in fact reflect reality, that maybe treating apnea doesn't make a difference to cardiovascular outcomes, specifically treating apnea with CPAP. Now, whether treating apnea with an intervention that prevents apnea throughout the night does prevent events still needs to be studied once we develop a treatment that's effective for the entire night. But we also need to take into account the effects of withdrawal of therapy during the night and the effects of not including patients who are sleepy, or those who also tend to be at highest risk for a cardiovascular event. So I'll leave it there, and I'm happy to address any questions, Shalini, that you or any of the other panelists may have. Thanks very much.
Well, thank you very much for this informative talk on cardiovascular disease and sleep apnea. Now, this webinar may be viewed by cardiologists or sleep physicians or clinicians, and so we received actually quite a few questions. So I want to kind of go through some of those here. So if a cardiologist is seeing a patient and they would like to screen them for sleep apnea, would they want to ask, does the patient snore, and then just send everybody who snores? Are there some tools that they may want to keep handy in their office? And then kind of how do they find that sleep center to start referring patients?
So that's a very important but difficult question to answer. Who do we send for a sleep study? Now the big thing we have to keep in mind is that by identifying the presence of sleep apnea and treating, do we confer any benefit on the patient? And the SAFE study would tell us that we're not really giving the patient much benefit if they're not sleepy, and with all the other caveats that I mentioned. So in terms of what we know now and whom we should refer, I would say that the sleepy patient with cardiovascular disease should definitely be referred. And then the patient with disruptive snoring, not just regular snoring, but snoring that is disruptive to the spouse and other people. And I would also refer patients who have a cardiovascular condition that is resistant to treatment, like resistant hypertension, heart failure that's not responding well to standard therapy, atrial fibrillation that keeps recurring, patients with a heart attack that comes on at night, I would definitely refer, as I would patients with nocturnal angina that wakes them from sleep. And the other group, of course, would be people with an implanted cardiac defibrillator in whom the defibrillator triggers at night. If it recognizes a potentially fatal arrhythmia and appropriately shocks the patient at night, then I would definitely consider a referral for a sleep evaluation.
Great. Another question is that given the information that you shared on your slides with hypoxia and the lowest oxygen saturation being independently linked to increased cardiovascular death is very interesting. So for patients who fail CPAP therapy or they've tried BiPAP, they've tried different modalities, do you recommend, or is there any evidence out there that we should even consider perhaps oxygen by nasal cannula, and that either alone or maybe even in combination with things like oral appliances for patients who have failed any type of PAP therapy?
So I don't have an answer to that. What worries me about oxygen therapy is that insofar as hypoxemia is the trigger for cessation of apnea, if we give people oxygen, we will then blunt that hypoxemic trigger that stops the apnea and allow the patient to have a longer apnea with greater CO2 retention. Now, again, this is a theoretical issue I have with oxygen therapy for sleep for obstructive apnea. I think before we go down that road, we certainly would need good evidence that doing that does make a difference to outcome.
Sure. And then another question that we had was, as of right now, adult sleep studies in general do not include carbon dioxide monitoring. So if we know that hypercapnia can be important in the apnea process, are you aware of any data that CO2 levels also independently might be associated with increased either cardiovascular morbidity or mortality?
Don't have those data, again, because of the very important point you mentioned, that CO2 is very hard to track during the apneas. But what data we do have suggests that if you give people CO2 but keep their oxygen levels very high, you will still trigger very high levels of sympathetic drive and raise blood pressure. So CO2 has been a neglected part of the pathophysiology of obstructive apnea, in large part because it's been so hard to measure.
Mm-hmm. Sure. Other things, obviously, on a sleep study, we typically will have 1 or 2 lead EKG. And so questions with that sometimes arise of the different types of arrhythmias we may see on that limited 1 or 2 lead EKG. And so as a sleep clinician, when should I be referring my patients to cardiologists for further evaluations? Is it that, nocturnal occurrence of atrial fibrillation? Is it, certain amounts or frequencies of SVT or PVCs or VTAC, or even oxygen saturations that are low at baseline? What are your thoughts on that?
So even with 1 or 2 leads, we should be able to pick up atrial fibrillation and things like ventricular tachycardia, other significant arrhythmias. And so if you see, runs of ventricular tachycardia at night or atrial fibrillation developing at night or even atrial flutter, then I would certainly refer the patient to a cardiologist. And I would also have a higher imperative for making sure that that patient is adequately treated for their obstructive apnea. Now, what can be difficult to pick up on a single lead or 2 leads is ST depression. So if the patient is getting ischemia during the night, that is less able to be detected with just 1 or 2 leads. The other thing that you will see on 1 or 2 leads is bradyarrhythmia, which can occur in a significant proportion of apneic patients, and which is often a manifestation of the diving reflex. And these bradyarrhythmias can be severe. You can get 10, 15 seconds of asystole, just no heartbeat, in response to an apneic event. And that should also be fairly clear on just one or two leads. Now, the problem here is that if you have one lead and you see a period of asystole, you don't know if it's artifact or not. But if you have two leads and you can see it on both leads, then it gives you a higher likelihood that the bradyarrhythmia is in fact real.
Sure. And then another question, I know we did not cover this in depth in your talk, but we have some questions about adaptive servoventilation in individuals who have obstructive sleep apnea and then treatment emergent central sleep apnea. And so we were wondering if you could comment on the SERVE-HF study and which patients we should be moving on to a different PAP modality versus those that can be treated with CPAP or BiPAP.
Right. So again, that's a very important clinically relevant question. Thanks for asking it. So SERVE-HF, just to recap, looked at people with stable heart failure who were optimally treated, who had predominantly central apnea, and who had ejection fraction of I believe 45% or below. And so the data from SERVE suggests that specific group of people with a low EF, in other words, systolic heart failure, with stable heart failure, with predominant central apnea, did badly when they were treated with ASV. And that finding should not be extrapolated to other situations of apnea, whether obstructive or central. In other words, those data do not mean that we shouldn't be treating patients with central apnea with a normal ejection fraction. And it certainly does not mean that we shouldn't be treating obstructive apneics with systolic or even diastolic heart failure. So we need to be very careful that the SERVE data, insofar as they're applied to clinical practice, are focused only on those kinds of patients that SERVE studied. Again, I'm emphasizing low ejection fraction systolic heart failure patients with predominant central sleep apnea who are stable. It doesn't apply to unstable heart failure patients. It doesn't apply to opioid-induced central apnea. It does not apply to any obstructive apnea with normal or low ejection fraction. And so I would not use those data as a reason to avoid using ASV in patients who did not fit the SERVE parameters.
Great, thank you for that clarification. And then, along the same lines of for patients who do have central sleep apnea and obstructive sleep apnea, or if they have treatment emergent central sleep apnea, are you aware of any data about, if they fail PAP modality, do we think that they will still get benefit even from alternative therapies like oral appliance therapy, or again, coming up with the idea of, do we try an oxygen therapy by nasal cannula?
So I think anything that can prevent the apnea would be useful, whether it's postural interventions, keeping them from sleeping on their back, whether it is a mandibular device. I think the mandibular devices are a good option, providing they are fitted by someone who's expert in that, so you don't cause any problems with the temporomandibular joint or with the teeth. I think with optimal fitting, they certainly are an option, and we do need more randomized controlled trials looking at efficacy of apnea attenuation with a mandibular device. So I think whatever intervention diminishes the apnea severity, again, whether it could be weight loss or bariatric surgery, that I think will be helpful. Again, whether oxygen will help, I don't know. I do believe that that an oxygen intervention trial in heart failure may have been approved to be initiated. I don't know for sure, but it would be useful to have randomized control data on outcomes with all the interventions that we talked about. And again, emphasizing the importance of these randomized control trials, because observational data are prone to so many subjective limitations that before we can take apnea treatment into standard of care, certainly for a patient with established cardiovascular disease, we really need those randomized control trial data.
All right. Well, we thank you very much for taking the time to share your knowledge and expertise with us. Is there any other comments that you would like to add before we wrap up?
No, I think, first, thanks for asking me to do this, and thanks for those really very important and insightful questions, which I think can, at least from my perspective, help clarify some of the ambiguities in the data. I think we should still be trying to find patients with apnea and certainly be treating them, particularly if they're sleepy. If they're not sleepy, there was some benefit, as we saw from the SAVE study, in terms of days off from work, and we have to understand why that benefit was incurred. What specifically did treatment do to prevent people from missing work? So yeah, I think we have a lot more work to do in terms of defining which patients are best suited to intervention, what is the appropriate intervention for a given patient, and we need to keep looking for treatments of obstructive apnea and central apnea maybe, but certainly obstructive apnea that are more complete, that really do diminish the apnea burden and that don't leave the patients unprotected for significant parts of the night.
Great. Well, thank you very much again.
Yeah, thanks, Shalini, and thanks to the ASM for doing this.